Good morning, class, future doctors. Obviously, I'm not in class this week. I'm actually out of the country this week, and I will be again in March as well. I have some duties with the Air Force I have to do, and Dr. Kang suggested when I brought it up to him before the semester started that I would have to be out of the country. He said, I'll just record their lectures. And for an old doc like me who went to medical school with books and cadavers, and didn't own a computer until I was in residency. That's easier said than done. I probably spent more time trying to figure out how to do this than it will take to do the lecture. So hopefully this goes well, and you guys will be patient with me as I get through this material. I would certainly much rather be there in person, but one of my duties as the chief of aerospace medicine is to be in charge of this humanitarian effort that we are doing in the summer with a couple of three bases. I have to go down to the site to set up some of the things, meet with the people that we're going to be helping to make arrangements. So I will see you next week. I'm going to share the screen. We're going to go over the endocrine system this morning. As a general rule, the endocrine system, we're just looking at glandular system of different hormonal functions. And as a whole, there are 5 different functions that we really look at when we think about the endocrine system. Honestly, the first 3 we're not going to spend much time with because we aren't really focused on embryology. We're not really looking at the development of the body. Really, we're dealing with more of what has already happened and the balance of those hormonal functions. But in general, first, there's a hormonal impact on the differentiation of the reproductive and central nervous system of the fetus. Secondly, there's a stimulation of growth and some development of childhood and adolescence functions and features. Some of you who are going to pediatric work may have to dive a little bit further into this as part of your practice. Thirdly, the coordination of the male and female reproductive systems. And then the things we'll probably focus on more as they're more applicable, certainly to my practice and probably what you'll see in practice, is the maintenance of optimal internal environment, how these hormones keep us in balance. The whole point of the hormonal system is to keep us regulated in homeostasis. And then finally, the initiation of a corrective or adaptive responses in emergencies. So essentially, how does the endocrine system help us with our flight or fight system? I won't go into a lot of detail. You guys are getting phenomenal instructions and great detail of anatomy. Went over to your anatomy lab and realized that I've probably forgotten more anatomy than you guys are going to be learning by the end of this year. And I was a teaching assistant for anatomy in medical school. So you guys are getting phenomenal detail structure. So I'm not going to go into a lot of detail on the different organs. As you can see, some are represented here. Probably the biggest things to understand is sort of the hypothalamus and the pituitary gland. Pituitary gland we refer to as the master gland, with really input and direction from the hypothalamus in the brain. And you can see those both on your cadaver and here, but I know you're getting good anatomy instruction on that. We'll talk about the neuroendocrine system, really where the endocrine system, the hormonal system meets the nervous system at the hypothalamic pituitary interface. So the hypothalamus, really think of that as the integrative center for where the endocrine and autonomic nervous system meet. If you look at this slide here, you can see, I'm going to get out of this so I can see the cursor a little bit. So up here in the top of the cursor is that you can see the hypothalamus, really sort of the input where the body is getting feedback, delivering that to the hypothalamus. And it will deliver through this hypothalamic stalk to the pituitary into both an anterior and posterior sections of that. Most of the hormonal effects come from the anterior pituitary. In fact, all of them except for 2. You have the posterior pituitary really controls the fluid balance of the kidney through the antidiuretic hormone. So diuretics, there's common diuretics you'll see in practice like Lasix and torsemide, these type of medications that induce urine production, make you pee off fluid, which is great for people who are in heart failure. Well, antidiuretic hormone has the opposite effect, is holding on to fluids. So this has a big impact on fluid and salt balance. And then oxytocin, you'll see more in maternal health, with pregnancy, the smooth muscle of the uterus, and the effects of the mammary glands with oxytocin. The rest of them are the anterior pituitary under hormonal control, whether it's the bones with growth hormone, ACTH, or adrenocorticotropic hormone affecting the adrenal cortex, basically the outside of the adrenal gland. We'll break the adrenal gland down a little bit more when we look at the impacts of both the outer layer and the inner layer. Thyroid stimulating hormone, or the thyroid hormone that is coming from the pituitary. That's a condition we'll actually talk a little bit more about. Will see cases of this and the impact of that. The gonadotropic hormones, basically some of the sex hormones, FSH, LH. We'll see effects with that. The testes and ovary, FSH and LH, we see a lot, especially around the time of menopause when those hormones start to go down. In fact, that's one of the ways we can measure that, to see what the effects of the ovary is and if somebody is actually in menopause. Although clinically, menopause is when you've not had any cycle or menstruation for at least 1 year. Melanocyte stimulant hormone, the production of how much melanin is in the skin, and the prolactin. I like this slide a little bit better just because it really is going to show the effect of the hormones and the relationship between the hypothalamus and the pituitary, and then out to the rest of the body. So if you look at the posterior pituitary, you see there's a direct release of hormones straight down into these different aspects of ADH and oxytocin. Where the anterior pituitary, there's an indirect. So there's a go in between effect with the hormones that come from the anterior pituitary to their target affected organ. Whereas you have direct control by the nervous system from the hypothalamus, which bypasses the pituitary altogether when it affects the adrenal medulla, the inside layer of the adrenal gland, which is really giving you your fight or flight response, the epinephrine, norepinephrine response. Obviously, the hormonal aspect is a much slower process where the hormones are carried through the blood supply. They're responding in a slower fashion where, you're about to be eaten by a bear. You certainly can't wait for the blood transfusion, so to speak, to go from point A to point B, which may take some time to be able to respond. You need to respond quickly. So that's why that's under a neural control and not a hormonal control. But you can see where you've got these actions taking place. If you look at the anterior pituitary, you'll see there's a go-between. There's basically a factory that is making the hormones. So, for example, the TSH coming from the anterior pituitary. So this is a thyroid stimulating hormone, have an impact on the thyroid, which actually is what makes the thyroid hormones. So these are stimulating hormones that have an effect on a factory that makes the hormones that then go out to the rest of the body. This is an example of what we're looking at in a little more simplistic fashion, break it down a little bit. You have the hypothalamus, which gets the input from the body of what is the need, and it has a releasing hormone. That releasing hormone speaks to the pituitary. Then the pituitary acts as that master gland and then directs the hormone, or gives what we call the stimulating hormone to an endocrine organ like the thyroid, like the breast tissue, whatever it may be. And then that produces the hormone and has effect on the target. The way I think about this, and what I encourage you guys to do, is to try to figure out how to break down very complex or medical terms into simple terms so patients understand it. So the way I describe this to patients is that, let's say if we're going into business. So the class, you guys and I, we're going into business. We're going to make the greatest business that we can even imagine. And so we're going to be the brains of the operation. And because we're busy and we have the great idea, but we're not going to make the product. We're going to actually get a factory. We're going to hire some factory workers, and then we're going to make we're going to make some shoes. We're going to be the next Hokas of the industry. I actually didn't know what Hokas were until last summer when Noah ran a marathon, and I was getting ready to go buy some new shoes for my running, and he told me about Hokas. I didn't even know they existed or what they were. But now I have a pair. So we're going to make the next great Hoka, and then we're going to sell them in the store. So if we thought about our product and if we looked at our product and we said, well, if we're making it, telling the factory to increase production, we make our product, we put it in the store. But if we look in the store and there's none of our product on the shelf because people want it, there's a very low supply of our product. Everybody's buying it, so it's not staying on the shelf. That information is going to come back to us up here in the headquarters, up in the brain. And we're going to say, what? What are we going to tell the factory? What's our message to the factory? You've got to increase production. We aren't getting enough to maintain product on the shelf. So we're going to increase our production. Same thing if we had too much production and people weren't buying our products. We don't want to keep making more and more. That signal is going to come back up here to the brain, and we're going to send a message that we have to decrease production to the factory. So the way I will look at this is the releasing hormone is basically that message that comes back from the consumer back to us in the hypothalamus or in the brain. We send a signal from the hypothalamus and the pituitary axis down to our organ. So let's say it's a thyroid. The thyroid now we're saying either make less, make more. Our product, the hormone, thyroid hormone, for example, T3, T4, whatever hormone we want to choose, and then we'll put that on the shelves. So this is the target. This is the tissues. I guess our store could be Target. And so that's what I would look at. So it's a negative biofeedback system. And this always confuses patients when they see the lab results. So if I get a thyroid stimulating hormone, that's the measurement of a hormone I'm measuring between the pituitary and the thyroid. And if it's very, very high, their level is high. Actually, I know that means that their thyroid production is low. And then I tell them, I need to give you more thyroid medicine. But it's always confusing to them to see that inverse versus if they've got way too much, the thyroid's overactive, I need to reduce the medication. So when I sort of draw this type of model out for them, then it makes it easier for them to understand the labs. But that's really the essence of what we're looking at here, to be in a homeostatic production and status within the body is just basically understanding this feedback system of how it works and whether it's stimulated or inhibited. But the whole point of the hormone system is to keep us in homeostasis. So this is an example of what would happen if you had an imbalance in your blood and you had basically not enough blood sugar to maintain function. Blood sugar, I think of as the fuel source, main fuel source of the body. And if your hypothalamus through these receptors in the blood says there's just not enough sugar there, that could lead to crisis. So that sends a signal back up to the hypothalamus, which is going to speak to the pituitary through sending its releasing hormone, the corticotropin releasing hormone. It's going to speak to the anterior pituitary, and it's going to say, we have to adjust our ACTH. And by doing that, it sends a signal down to the adrenal gland, and it's going to increase the glucocorticoid release, increasing blood sugar. And once that blood sugar level gets back up to a normal level, then that process will turn off. And that's the whole point of the system, is basically just being able to find if you're deficit, bring it back up. If you're too much, try to bring it back down. And then you can just apply whichever hormone in that model to figure out where we're at. If we look at the hypothalamic pituitary axis disorders, so what happens when that does not find that homeostatic balance? What happens when the system goes out of whack and it's just not working well? Well, you're left with some type of syndrome, and it's either going to be a hormone excess or a hormone deficiency. So you end up with a hyper or hypo condition. So, like for example, the thyroid, hyperthyroidism, too much thyroid hormones being produced. Something is messed up in that balance where it doesn't turn it back off. Or hypothyroidism, there's not enough hormone. Something in the system does not allow you to correct for that, so you remain in a deficit. Now, there are some things in the hypothalamic pituitary axis that may not be hormonal, that may still have a negative impact. An example would be a visual impairment from an optic nerve compression. Um, so I know it's a lot of stuff, and I think just all the stuff you guys are going through right now probably leaves you feeling like this, right? It's just kind of stressed out. And it's interesting to see how stress is impacted with the endocrine system. There is a natural process where we know that by increasing our performance, we need to increase our stress. But there's a balance. And so as our stress level goes up, our performance usually will start to peak. Now, there's a comfort zone where you're kind of in a nice balance between enough stress that's not overwhelming, that maximizes performance. Then there's just a little extra stress. And I sort of think about this as like, why in the world do we test you? Why do you have to go through all this stuff and you're learning it, you're going through it? But what's the point of testing? It's not just to check knowledge, it's actually, to be honest, it actually maximizes your performance because you get that little extra stress. If you only had to listen to lectures and never had to take a test, you would stay a little bit lower on this comfort zone and you wouldn't maximize your performance. So sorry about the testing, guys, but it actually will help you to maximize your performance. The problem is when you overshoot this curve with too much stress, then you actually have a decrease in your production, a decrease in your overall health, and it leads to bad health, exhaustion, decrease in performance, and eventually even a breakdown mentally or physically. So we're trying to hit that optimal stress level. Now we can't stay in an optimal stress all the time. There's gonna be times you're gonna kind of go down and go up, depending on what the situation is. Um, you don't want to stay down here with too little stress all the time. Leads to boredom, apathy, depression. But too much will also lead to panic, burnout, depression. So we're always trying to figure out this balance. But what's interesting is it's not just emotional stress. This is the same neuroendocrine response you have to both emotional, physical, psychological, and spiritual stressors. And the body will respond to these things across the board from the endocrine system. So the main thing that we end up seeing is the effect of the catecholamines. So when we say catecholamines, we mean dopamine, norepinephrine, and the epinephrine responses. So there's a physiologic response to stress, which we sort of know, right? That's something I think we can observe, and we all are aware of that. There's sympathetic nerve endings, and the effect of the catecholamines on the system, on the neurologic system that impacts the endocrine system. So if you pump up these catecholamines, you're going to get increased rate and force of contraction of the heart. It's going to beat faster. It's going to beat harder. It's going to beat more efficiently. You're increasing your cardiac output. You get vasoconstriction because you're not trying to drop your blood pressure. You're trying to raise your blood pressure up and try to get blood and oxygen and nutrients to the tissues so they can respond. And it will bump up your glucose and your lipids so you have an energy source. Right. So this is, like I said, this is the bear jumping out of the woods. You need to be able to respond quickly and right away, and it's the catecholamines that will do that. Now, there are conditions where the catecholamines will go kind of out of whack from a tumor, and we'll see the same type of response, but not under periods of stress. We'll see uncontrolled high blood pressure. We'll see flushing. We'll see, anxiety and rapid heartbeats and all these different things when these tumors are producing these at an abnormal level. But the whole point of the catecholamines is to prepare the body to fight or flight. This is, you need to be able to take action quickly. Stress is commonly associated with the catecholamine release. You see this with exercise, you see this under thermal changes. So, your body tries to respond, whether it's shivering or, the response to a thermal change. But we also see this with acute emotional states. And I think being aware of, where you guys are at and where your patients are at when you're under any type of stress, the body still wants to respond in the same type of way. Now, under physical exertion or physical stresses, the body has a more abrupt change than it does under acute stresses, but you will still have some increased response to any of these type of stresses. So the main thing that we'll see with stress is the cortisol response. And I think we're seeing this more even in popular media or different outlets, the effects of cortisol. So cortisol is this principal glucocorticoid um, uh, hormone, that's released from the adrenal cortex. Now, we also see this a lot with clinical conditions. So the body produces its own steroid, but we use steroids all the time for things in medicine. And so it could be a synthetic steroid that could have the same type of long-term impact, such as, prednisone or a synthetic hydrocortisone. So the principal glucocorticoid that's released, it's in response to that stress, or it could be under the low blood sugar levels like we saw before. But when we release cortisol, we're increasing the things that we need that will be used as fuel source and for energy, whether it's protein, carbohydrates, things to get the blood sugar back up. So it's our fuel source, and it's like pumping the gas, into the tank when you really need it. You need it as a general rule just to maintain the amino acid availability so you can make protein synthesis. So it's very important in having some availability just for tissue repair, although excess amounts will actually lead to a detriment of the muscles. It's essential to have the cortisol in the norepinephrine-induced vasoconstriction. But like I said, too much, it can actually dampen the inflammatory response. So it will impact the fibroblast proliferation. So it can actually impair healing, which I see in clinical practice all the time. I see people trying to heal from wounds, but they're on a steroid or they have steroid excess for whatever reason, and it really impairs their ability to heal wounds. And this is where I see people having significant wound lesions, decubitus ulcers, holes in their feet that will lead to amputation because they can't heal. So chronic stress, and now you've got a prolonged level of cortisol production and exposure. Well, when we have chronic stress, we sort of all know that we're going to have an impaired cognitive performance. We just don't function well when we're under prolonged periods of stress. That's when we kind of go over the top of that curve, and now we're on the downside. But excess cortisol will suppress the thyroid function. It impairs the ability to maintain that homeostasis with blood sugars. So you tend to have a more excess amount of sugars in the system or have hyperglycemia, too much sugar. Decreases the bone density, it disrupts the sleep, it messes up the muscle tissues like we talked about, raises your blood pressure, lowers your immune and inflammatory response, and it increases abdominal fat. It actually can lead to fat deposition in other places in the body as well, which we'll look at later when we talk about Cushing's. Impact of stress, things to just watch for. So when you're working with patients and you're just seeing how they're doing, you may actually see manifestations of these things. So you'll see a lot of emotional symptoms. They become quite common in our society. They can be common for other reasons as well, but you'll see people get much more agitated and frustrated easily. Moods are flipping around, up and down, much more moody. There's a sense of feeling overwhelmed. There's a lot more difficulty with keeping control, and it's just hard to kind of relax your mind, right? You end up having this low self-esteem, just from this chronic aspect of stress. So there's a physical and mental and emotional component to the prolonged stress and prolonged cortisol um, production. Cognitively, you see worrying, racing thoughts, inability to focus, and poor judgment. So I put down here uh, that I would say be a wingman. Now, the wingman concept really is an Air Force concept. And it is the idea of like when two planes are flying, you've got one that's kind of watching the six or watching the back of the other guy. So you're kind of watching out for each other. So the wingman concept is really a thing that is kind of throughout the Air Force. So when I was in officer training school, when I was in my aerospace training, we were always connected with somebody else. We always had a wingman, somebody that was always watching out for us, somebody that made sure, we're partnered up and we know where each other is at. We know if somebody's going to go out and do something. We know when we're supposed to show up and if our buddy is there or not there. So I really like the idea of the wingman concept. I like the idea of watching out for each other. You guys are going through a lot of stuff. These next, 3 years are going to be pretty intense. And one of the things I think is awesome about Fox is I love the way you guys actually do kind of watch out for each other. You are wingmen. Just encourage you guys keep being wingmen for each other, but also just make sure everybody has a wingman, just so that it is something you guys are all going to go through. It's like you kind of fly together, you succeed together. So keep doing what you're doing. Stress symptoms with physical impact, things to watch for when you're working with patients. Watch for the clenched jaw, grinding teeth, poor energy. It's a lot of things that will come into the office and people will complain about symptoms and we'll look for physical things. And a lot of times it isn't something physical. Like you can have, pain in your jaw and it's TMJ, but that may actually not be just TMJ. It may be because you're grinding your teeth because you're stressed at night, and that's why you have that. You may not have an underactive thyroid or anemia because you have low energy. It's just that you're too physically exhausted because of all the stress you're carrying. Headache is extremely common. People carry their tension in their neck, in their shoulders. They don't sleep well. And headache's just a manifestation, not of a physical problem, but it's a physical manifestation of an emotional or stress response. For sleep, same thing. Muscle pain can be the same thing. So just because it hurts doesn't mean there's something wrong with the actual organ or structures. It may just be a physical manifestation of an internal emotional thing that somebody's dealing with. We see behavioral symptoms as well, change in appetite, procrastination, substance abuse. These are very common things where I see people will turn to drugs or alcohol because they're trying to medicate themselves to deal with things that they're dealing with, whether it's maybe physical pain or a lot of times mental and emotional pain. And so um, it's a very tricky thing with, say, something like alcohol, where it is something that will take off the edge. It seems to help at the beginning, but I would say it's like the friend that invites you in the front door and then kicks you in the rear out the back door, right? It makes it a little bit better at first, but it actually makes the whole process worse. For example, like with sleep, it will help you get to sleep, but it will keep you from being able to stay asleep. A person is more likely to have sex because they lower their inhibitions, but then they're less likely to perform physically because of alcohol. So watch out for people trying to self-medicate or self-treat because of an underlying condition, whether it's physical or mental. Um, it's a big impact on our overall society, and the economic impact is huge. So up to about $300 billion in the state they looked at based on the impact of stress and pain. Uh, not just because of the loss or the cost of care related to those conditions, but also just the indirect costs because the production went down significantly. So people just weren't working, weren't able to work. They got on disability. They had to work less hours. It's a huge impact. And if we just paid attention to people and the things that they're dealing with, we could have a significant impact on our overall society production and just being better citizens, being more productive, and actually just being happier. Um, so let's get into some specific endocrine disorders. So we'll look at some things when the pituitary and the endocrine system is just not working right. So remember, the pituitary is the master gland. It's connected to the hypothalamus through the pituitary stalk. So that's our neurohypophyseal tract. The anterior pituitary, we call the adenohypophysis, that's controlling the hormones ACTH, TSH, the thyroid, the luteinizing hormone, the follicular stimulating hormone, the growth hormone, and prolactin. Posterior, remember, it is a direct neural hypophysis. It's not having an in-between or a go-in-between. That's the antidiuretic hormone and oxytocin. Anterior lobe disorders, certainly more common. It's most often caused by something that is an abnormal growth, a tumor. It can be by genetic disorder. We'll also see it because of trauma or potentially pituitary infarctions, which is not as common, but it can happen. So if you lose blood supply through a stroke or some other process, a blood clot, a bleed, and then you lack oxygen to that tissue, the tissue can be damaged, and then they can't produce the hormones that it's designed to do. Hyperpituitarism, you have an excess secretion of one or more of those hormones. The effects that you'll see, the symptoms that come about will really depend on which hormone secreting tumor it's affecting, what hormones being produced in excess. And it can be more than one, but symptoms are depending on whichever hormone's affected. Hypopituitarism, a deficiency of those hormones, typically caused by some type of destructive process. So this is where you'll have the ischemic injury, but we'll also see this when people are having surgical interventions. They're doing something, they're removing a tumor, maybe it's a benign tumor even, like a meningioma, but it's just in the wrong place, or it's too close to the pituitary, and it's affected. Radiation is something that we'll actually see. And then there are inflammatory, whether it's infectious disease or inflammatory conditions that can also impact and destroy the function, causing hypopituitarism. So think of the manifestations. If it's an underactive pituitary, you're not producing your hormones. So you're going to have a growth, a deficiency of whatever that hormone is. So if it's growth hormone deficiency, no growth. So short stature, delayed growth, delayed puberty. If it's the adrenocortico or the steroid portion of the adrenal gland, you're going to have aspects of difficulty of controlling your sugar. So hypoglycemia is going to be a big problem. That can lead to nausea, vomiting, abdominal pain. And we'll see that we'll see orthostatic hypotension because you can't maintain your volume to maintain your blood pressure. And orthostatic hypotension is a specific type of low blood pressure that we'll see that is worsened by standing. So when you lie down, blood pressure is not working against gravity to get to the brain. But when you stand up, you may not have sufficient enough response to be able to get that blood up to the brain. So I think about it like a hose. If you took a hose and you sprayed the hose and the water came out this far, then that's not a problem. But then if you turn the hose up, the fluid doesn't go up as high because of gravity. It will only spray up to a certain level. Now, to get it back up to that level that it was at when it was this way, you can do one of two things, right? You can turn the pump up, you can turn the faucet, or you can put your finger over the hose and narrow the diameter. And that's normally what the body does. The body will basically either start to beat faster, the heart will beat faster to pump up that response, or the blood vessels will constrict, decreasing the diameter to increase the pressure to get to the brain. And orthostatic hypotension, you can't actually manifest those two things to increase the blood pressure or to compensate. And so the blood pressure will drop when you stand up. We'll see this really commonly with dehydration. It'll manifest the same way. If it's your thyroid, it leads to fatigue, some cold intolerance, menstrual disturbances. We'll talk about the thyroid a little bit more detail. Gonadal failure, obviously decreased sex drive, erectile changes, not having your normal menstrual cycle, infertility issues, and you'll lack the ability to produce secondary sex characteristics. Like you may not have the normal Tanner stages or normal hair growth, or like say a beard for a guy, or muscle development, growth of breast tissue or the testes. If you have neurologic manifestations from hypopituitarism, that's usually produced by a tumor, and is causing compression on the tissues. The things we see with that more commonly are going to be headache and visual changes. And specifically because where the pituitary sits, it sits right next to the optic chiasma. And I think you guys have had this in a lecture before, or you'll get it in a lecture. But if it's in the pituitary, you'll get something called a bilateral temporal hemianopsia. And just a reminder for this, if you looked at the optic chiasma right here, the pituitary is sitting here. If you get a tumor there and it starts to press on this, you can see where the tracks kind of go. I'll let you be able to follow the tracks, but ends up with this vision where you have this loss of vision on the bilateral temporal or the outside visual fields. And that's the manifestation that you'll see with the neurologic impact from tumor growth. If you have too much hormone, so if you have an excess of growth hormone, for example, it depends on when this happens. If this happens before puberty, essentially what that means is before the epiphyses close, you end up getting something called giantism. This is where, you get the super tall, super abnormal overall growth feature of individuals like Andre the Giant. So hopefully you guys know who Andre the Giant is. If you don't know Andre the Giant, and if you don't know the Princess Bride, I'm just gonna have to fail you now because that's just not acceptable. We'll have to fix that. So if it happens after puberty or after the epiphyses close, it's not going to cause an ongoing elongation of the skeletal muscles and growth. But once they're closed, you'll still have some increased growth, but at least the acromegaly. So you don't keep growing tall, but you'll start getting thickening of the bones. So you see these very broad shaped hands and spade-like fingers, very prominent features like a protruding jaw or bossing forehead, thickening of the nose, ears, and tongues. And you can get, ironically, even though you got this growth, you actually end up with a muscle weakness, or what we call myopathy. There's some different reasons why we think that happens, but it's kind of paradoxical when you have this increased growth and increased masculine type features, but actually can lead to a muscle breakdown. So these are examples. When you think about acromegaly, think about Tony Robbins, right? So Tony Robbins, very prominent, big guy, big hands, very, masculine, prominent jaw line. And then Andre the Giant, famously here in a scene with the Princess Bride. And then I love this picture down here with him with Muhammad Ali. So Muhammad Ali, obviously this great fighter, he's, massive hands, and you puts his hands up next to him and it's just like, just dwarfs his hands. And then one of my favorite scenes, Fezzik's here and he's meeting the man in black, and he's supposed to take out the man in black, and the man in black is like, well, so you're saying you put down your rock and I put down my sword and we try to kill each other like civilized men? And he's like, well, I could kill you now. And he goes, well, slightly, I think the odds of hand fighting are slightly in your favor. And he goes, well, it's not my fault. I'm the biggest and the strongest. I don't even exercise. So if you're already a giant, I guess you don't have to exercise. The rest of us, we need to exercise. Growth hormone deficiencies. So this, we aren't really going to see this in adults because the growth has already happened, but we see this in children. And this is typically caused by some abnormal gland formation, often coming from an abnormal chromosome deficiency, some type of genetic disorder, something that has affected that from early on. With a deficiency, there's a hyposecretion, either from the hypothalamus or from the pituitary, where it's failing to produce the hormones. You can see this with brain tumors like a glioma, basically a tumor on the nerves, like the optic nerve. Children who have radiation or maybe have leukemia or something that's affected the brain, they get radiation. It actually may lead to destruction of the pituitary. Trauma can induce it. Sometimes trauma with prolonged labor or breech deliveries can actually lead to this impact on growth deficiency. Thyroid, if you have too much of the thyroid, you're going to have hypothyroidism. Unfortunately, I don't see hypothyroidism that often. I see hypothyroidism all the time. Hyperthyroidism is not as common, thank goodness, because it is actually way more difficult to treat. But obviously, you're producing too much thyroid hormone. So an example is a Graves' disease, and I think we talked about that before, but it's an autoimmune process. And basically, you have this thyroid stimulant immunoglobulin. So you basically are producing this process through this autoimmune stimulation that you're stimulating the thyroid just to go to respond not to the normal signal, but to this abnormal signal from the TSI that overproduces the production of thyroid hormone out of the thyroid. Well, that causes a lot of swelling of the thyroid, creates what we call a goiter. So one of the things that I really want you guys to get used to and start doing is thinking about the physical therapy neck exam. You guys are going to be working on people's necks all the time. And learning how to do a thyroid exam, I think, is going to be actually helpful so you can sort of figure out if there's something else that's going on. Um, I really think that you guys um, are going to be the next level of physical therapist, right? You're going to take that doctorate to something that's going to mean something in a clinical setting, right? It's like, you gotta love the PhDs and the knowledge they have and the information they bring and the studies that they can go through. I mean, but they are doctors of philosophy. You are going to have a clinical doctorate, which means you need to be practicing in a clinical manner. So learning how to actually feel the neck, but if you're feeling the neck, go and reach around and feel the thyroid. So the main thing is when you check the thyroid, you're going to actually learn to feel, but you'll reach from behind the patient, which you probably are going to be back there checking on the neck and other things anyway. And you're going to put your hands down and learn how to feel. And I'll show you guys more in person if you guys want to go over that, but you're going to learn how to feel where the thyroid sits. And typically what you'll have them do is take some water, put it in their mouth, and you get your hands ready and you swallow, and you'll be able to feel if the thyroid is actually moving. Now, typically the thyroid is not easy to palpate, but you should get used to feeling that. So if you do feel some increased tissue mass there, it may be a sign that there's a goiter. Hyperthyroidism is the most common cause of thyroid toxicosis, or an abnormal full body response where you go through like what we call a thyroid storm. The body gets all jacked up and overactive. We typically see this more common in women, just like we do an underactive thyroid, about 4-to-1 women to men. There are genetic factors that can play a role in this. There are clinical manifestations to keep an eye on. If it's affecting the thyroid diffusely, you'll end up with a goiter. You'll end up with a large thyroid. If there's too much thyroid production, you'll end up with something called exophthalmos, which is kind of bug eyes. I'll show you a picture of that. You can get edema in the orbital content, which actually will push the eyes out quite dramatically at times. So if you're feeling for the thyroid, this is an example of what to be looking for. So let me get out of this. Uh, the cricothyroid ligament. I don't know why that keeps popping up. But basically you can see that right here. So if I'm going to do, an external airway, I'm really cutting through this membrane to put a tube in through there. But the thyroid basically sits down below the thyroid cartilage and below this ligament and sort of sits on both sides of the trachea. There's a little isthmus or a little bit of what we call an island that kind of connects the two. Just of note, if you look at the thyroid gland from the back, you'll have these things called parathyroids. The parathyroids have nothing to do with the thyroid at all. It's just because they are located there anatomically. It really have more to do with calcium balance. But that's what you're going to be looking at from a standpoint of feeling for the thyroid. So this is an example of a thyroid a goiter. I'm quite confident you guys will not miss here on the left of the screen. But sometimes the thyroid can actually be enlarged or have a goiter, but it may be very subtle. And in the case of the lady on the right, you can see it, but you can imagine, when you start seeing, our population whose body mass index has just continued to go up and up and up, that actually can be quite easy to miss that as well. So I think learning to kind of feel for that will be helpful. Hyperthyroidism, basically, when I think of hyper and hypothyroidism, I can go through the details and we'll look at some of those details and symptoms. The way I describe it to patients is this. If your thyroid is underactive, it's like the battery is just running out of juice. If you have an overactive thyroid, it's all jacked up and it's kind of on overdrive. So pick your system and then decide what it would do. So for an example, if you have a hyperthyroid and you have an increased metabolic rate, well, if everything is jacked up with the skin, you're going to be warm and flushed and have heat intolerance. You're going to be sweating, right? You're going to have this excess production. You're going to have weight loss because your metabolism is going to be all jacked up. You're going to have a good appetite, but you won't be able to keep up and you're going to lose weight. You have an overactive sympathetic nervous system. Your heart's pumping, your heart's racing, your heart's going to have an enlargement because it's working hard. It also makes you more prone to having atrial fibrillation or a heart arrhythmia where the heart is beating erratically. Nervous system, you're more likely to get tremors, right? Everything's jacked up. It's like you're on 10 Monsters or whatever the energy drink is that's popular today. I don't know. I don't know the energy drinks. Hyperactivity, anxiety, and trouble sleeping. Muscles actually end up getting weak. They start to atrophy. You actually end up with more arthritic changes. The GI system, you're more likely to have diarrhea, malabsorption. Bones, you're more likely to be led to osteoporosis. So the reason I would rather treat hypothyroidism versus hyperthyroidism, because hyperthyroidism, it's hard to suppress an overactive system. You're trying to put the brakes on it. So there are some drugs that you can use that will decrease the thyroid hormone secretion, but you're really just trying to hold the waves back as they hit the beach. Sometimes you can do that, but oftentimes it's very, very difficult for those medicines to overcome that overwhelming high production. You can use medicines that can help decrease the response of the symptoms, like a beta blocker. So beta blockers are medicines we'll use for heart rate issues and blood pressure issues, but they block the hyperadrenergic system. So they're trying to take down some of that epinephrine type of effect that you'll have on the body. Iodine can be used. It'll block the release of the thyroid hormone. That's why you'll also see thyroid disorders in countries, not so much the US, but in other countries where there's iodine deficiencies, you'll see issues because you need to have that balance. And then there's radioactive iodine, or there's surgery. There's things you can do to go in and destroy the thyroid, which in most cases is more effective than trying to block it. Is you basically go in there and try to just destroy it, and then you can actually replace what you're lacking a lot easier and fine tune it much easier than trying to just hold back the waves crashing on. So this guy here in this picture is showing a sign of exophthalmos. So he's not surprised, right? He's not in shock. He's just that's just him resting on the left. But he's got orbital edema and his eyes are basically popping out. So if you looked at him from the side, the eyes are going to actually be prominent. And so this is before he received treatment for an overactive thyroid or hypothyroidism. And then after treatment, then you can tell his eyes have gone back to normal, and what he would normally look like. But yeah, if you see somebody that looks like they're in in a cartoon type of thing or a shock, and it's all the time, think of pressure behind the eyes and definitely think about the thyroid. An underactive thyroid, just the opposite. Instead of everything being jacked up, everything is slowing down. It's a deficiency of the thyroid hormone. It's about 4% of the population, but um, I feel like it's actually much more common. It's actually the only condition I know people are actually sad that they don't have. I have people come to the office all the time. They're overweight, they're tired, they're sluggish. They're under that chronic stress, and they're like, oh, if it was just my thyroid, I could take a pill and fix it. And so when I don't have the condition or the diagnosis of hypothyroidism, they're pretty disappointed. But it is fairly common that we'll see this. The risk does go up with age, and that can just sometimes be because the thyroid can start to atrophy. It can just kind of start to wear out and start to decrease that hormone production. We see it certainly more common in women than we do with men, although it can affect both sexes. Just because something is more common in one sex versus the other, don't forget to think about it in either sex if it fits the pattern. It can be congenital, it can be something we acquire, or it can be something that happens through the autoimmune process, like Hashimoto's condition, where basically the body will start to attack the thyroid. Remember, we talked about that last week. The body recognizes the thyroid as not being self. It's foreign, and the body wants to attack it. It starts to destroy it. So the production of the hormone will go down. Manifestations of the symptoms are just the opposite of being jacked up. It's all slowed down. So whatever the system is, it's just lower. So you start to have constipation, not diarrhea. You start to get more fatigue. You get more depression than you do anxiety. You get a slow heartbeat. You will start to see some changes in the hair, some thinning of the hair, and some hair loss. Interesting with hypothyroidism is that there is something that you'll see, like the lateral third of the eyebrow will begin to thin, and that's actually sometimes a sign of a hypothyroid disease. So you can see some of the symptoms here. A lot of times you'll see people that look like they have dementia because they just can't concentrate. They look like they're depressed, and they can't think well. So it's a manifestation of what we call pseudo dementia. We see that with depression as well. It looks like they have memory problems, but they don't really have memory problems. They have an underlying medical condition that is actually keeping them from being able to retain things in the memory and to concentrate. So that's one of the things with any dementia case. Whenever I have a patient with dementia, before I will diagnose them with dementia, I have to rule out other medical issues that could be the problem. So, for example, thyroid, a B12 deficiency, something we call normal pressure hydrocephalus, where there's too much water in the brain. And those are all what we call fixable or reversible causes. If I find those early enough, I can fix it and the memory will go back to normal. And it's important we look at that. I did have a patient several years ago. I mean, still my patient, but several years ago, he came to me as a new patient, and he came to me with the diagnosis of dementia. And he was mildly demented. It wasn't terrible, maybe moving towards moderate dementia. And I looked through his records, and he really had never had any type of workup. And I said, well, just to be thorough, let's take a look at your blood test just to make sure there's not something there. Well, Lo and behold, he had both a B12 deficiency and a hypothyroid condition. So I corrected both of them, and he probably got worse slower, but he did not reverse because he had had untreated condition for too long before he came to the practice. So you don't want to miss the opportunity to fix those things. But um, it is important with newborn screening that we check for this because it will affect their ability to develop and for the brain and the rest of the body to function normally. It's actually quite easy to replace. It's one of those conditions where I can just measure the level of the thyroid, typically using the thyroid stimulating hormone or the TSH, and looking at the biofeedback and just adjusting the medicine to make sure that TSH gets in the right level. It's like checking your oil. You're a quart low. I'm going to give you some extra thyroid, recheck it, see where the level's at. So it's actually quite easy to treat hypothyroidism versus trying to hold back the storm with hyperthyroidism. So this is an example of somebody who had hypothyroidism before on the left in 2005. Her picture, you can see she's a little puffy. She's looks a little tired. But quite honestly, how many people in our society just look like this anyway? And when people have conditions for a long time, they just get used to having the conditions and they get used to the symptoms, and their symptoms are just normal to them. So they don't think about it unless they go and see a doctor and they may say, "Hey, doc, I'm just getting a little bit fatigued. I'm having trouble with this, whatever it may be." Well, it's a simple condition. Check the thyroid, check the blood test. And you can see the picture in 2009 after she was treated, right? Looks like a way happier, healthier individual. But if you're not looking, you're not going to see it. So you can take a break now, but then again, you're on video, so you can take a break whenever you want. So I'm just going to push on. The adrenal gland. So if we look at the adrenal gland and we look at the outer cortex, the outer cortex really has the function of a couple of different things. So it's the glomerulosa, the fasciculata, and the reticularis. All three do something a little bit different. The outer layer of the outside cortex, the outside layer, really has to do with the mineralocorticoids. So it's really a steroid hormone that really affects our fluid and mineral balance. So when we're talking about water and salt balance, that's really coming from the outer layer of the cortex, the glomerulosa. The middle layer is affecting the glucocorticoids. It's controlling the blood sugars. That's the fasciculata. Not that I think you really need to know those levels, but what the cortex is doing. And then the inner level of the reticularis is the androgens, the sex hormones. Now, the inside of the adrenal gland, that is, remember, that's the neural tissue directly from the hypothalamus. That is our fight or flight. That's our epinephrine, and our norepinephrine response comes from the medulla. Anatomically, I think you guys know the adrenal gland is just basically like a little cone-shaped structure, like a little hat that sits on top of the kidney. The medulla is part of that sympathetic nervous system, the fight or flight. The ganglion produces the epinephrine, norepinephrine, releases it quickly in the blood for rapid adaptations to whatever the environmental stressors are. So it can be the fight or flight, but it can also be physiologic. So if you're having a significant decrease in your blood glucose, which can actually be life-threatening, or a low level of oxygen, your body may have this rapid adaptation through the adrenal medulla to try to correspond. Or inversely, too much carbon dioxide or too much angiotensin, which is what's affecting the blood pressure. So your blood pressure may be shooting way up. And if it's shooting way up, it may have abnormal changes or a risk for things like stroke. And so it may try to adapt to that environment fairly quickly. Now, what's interesting with the adrenal medulla is that if you have too much of the presentation of that, you're going to have a hyper presentation and sweating, hypertension, tachycardia, palpitations, right? I mean, just think about too much epinephrine, right? You're just all too much adrenaline that is being popped up. And that's what adrenaline comes from, because it's coming from the adrenal gland, specifically the medulla. But interestingly, if you have a lack of that, you have no symptoms. It's not going to manifest anything unless you need to respond in a fight or flight situation. You won't be able to. not in the same manner. So, but just at rest, there are not going to be any symptoms that you have a problem. The ACTH, or the adrenocortical hyperfunction, um, is when you're going to get too much of the steroid or too much of the cortisol. Um, I'm going to put um, a quick pause. All right, sorry about that little pause. Dinner was done in the oven. Had to let my daughter know to pull that out. ACTH hyperfunction, too much steroid in the system, leads to something called Cushing syndrome. Um, uh, Basically, if the pituitary tumor is just putting too much out, you're going to get an excess of steroids in the system. So you're not likely to see a lot of patients with Cushing syndrome. You will see some Cushing um, disease manifested, manif, manif, manifestate. Oh man, manifested. Sorry, I'm still trying to get ready to get out of the country here. Um, because we are doing it to people. So this is the iatrogenic condition where we are giving somebody steroids for some condition, and so we are excessively giving them exogenous steroids. It's not coming from the adrenal gland itself. So when you got a patient with chronic asthma or COPD and they can't breathe well, and the way to keep their lungs open is by using steroids, or they're using steroids for rheumatoid arthritis or some other chronic inflammatory disease that we're trying to suppress the immune system, which is great. You got to breathe, you got to be able to move, but you're going to pay a price to be on those steroids. So when you have an overproduction of cortisol or steroids, it's going to cause a liberation of amino acids. You're going to break them down from the muscle tissues, and you're going to lead to a weakening of the protein structure. So with excess steroids, you actually end up with what we call steroid myopathy or steroid-induced muscle weakness. Um, People use steroids to help build the muscles up, but at some point it actually has the opposite effect. All right. So these are things that you're going to see when you have an excess amount of steroids in your system. Uh, the lady on the left of the screen there, I mean, it's a woman, and she just has Cushing's disease. So she has something called hirsutism. So she's got excess masculine features, hair growth in a male pattern distribution. So obviously, kind of on her eyebrows, upper lip and her chin. You're also going to see people who are going to have excess production of tissues that will be built up. So increased steroids in the system actually induces the pancreas to produce more insulin. And insulin is going to go and affect the fatty tissues within the body. So this is what we call a buffalo hump, where you get this excess this fat pad on top of the back of the neck. You can actually see an increased production of fat pad over the collarbones as well. And you really, the collarbone should not be covered by a lot of fat. Even in my fat body, I can still feel my collarbone, without any difficulty. You get excess fat distribution in the face. You get what we call a moon-shaped face. And then you can get increased abdominal striae. So this is a male. You can see stretch marks in pregnancy, but this is happening because of excess steroid production in a man there. So, those pictures, I skipped a slide there, I just realized. Those are the signs and symptoms. So decreased glucose tolerance. So sugars are going up, gives you the moon face, gives you the buffalo hump, fat pad on the abdomen, the hirsutism, the extra growth, muscle breakdown. You also can get a lot of edema. And unfortunately, because you're pushing that all up and the adrenal gland on the cortex is being affected, It's going to affect your mineralocorticoids as well, which will affect your water sodium balance. And through the kidneys, sodium and potassium are exchanged. So if you're holding on to a whole bunch of sodium, you may actually be dumping a whole bunch of potassium. So hypokalemia or low potassium can be very, very dangerous. So you have to watch for that. Medical interventions, obviously, if you've got too much, you want to try to decrease the ACTH production. You need to monitor the weight. You need to monitor electrolyte and fluid balance because of the mineralocorticoid changes that go with it. So the pictures again we looked at. And then we're going to sort of finish up here with some diabetes. This is the thing you're going to see all the time. There's probably not a patient in my practice I don't see every day at least one diabetic, if not more. We see a lot more diabetics now than we ever did in the past, and I think that's because a couple of different reasons. One, we lowered the threshold for making the diagnosis of diabetes about 20 some years ago. So when I was kind of going into medical school, sugar tests had to be 140 or more for it, and then they dropped it down to 126. So we have a lower threshold to meet it. Two, I think we're just more aware of it. We're looking for it more, so we're catching more. But it's very, very common. And when you think of diabetes, it's not just high sugars, but think about a chronic systemic disorder. Essentially, it's a hyperglycemia. It's too much sugar in the blood. So I think about diabetes as having the sugars or the carbohydrates being like the main fuel source of the body. So it's like the gasoline for the car. And then the blood vessel is where the equivalent of what I would call like the gas tank. That's where you're going to put it. Now you want to get that sugar from the gas tank out to the engine, right? So you want to get it out to the engine of the body, which is going to be the muscles or whatever tissue is utilizing this. And so if you have a disruption in the metabolism of those carbohydrates and fats and proteins, it's going to lead to an imbalance, and too much of that gas is going to sit in the gas tank. Too much of that is going to sit in the blood vessel. You're not getting it out to where it needs to go. Now, the pancreas is trying to help control that. So if you have an excess number of carbohydrates, sugars in the blood, the pancreas tries to put more insulin in there, and insulin is basically the hormone that is going to take sugar and help transport it to where it needs to go. I always say it's kind of like the gentlemanly hormone that is trying to be a gentleman and hold the hand of the sugars and escort it to where it needs to go, to get it safely to the muscles, whatever tissue. But if you have defects in the production of that insulin or defects in the effect of the insulin or both, then you'll have an excess amount of sugar that stays in the blood. And just like too much gasoline sitting around on the same tissue can lead to corrosion, right? So long-term damage of the eyes and the kidneys and the nerves and the blood vessels in particular are things that we have to watch for. So there's a couple different types of diabetes. You guys have probably heard this, type 1 diabetes, also insulin dependent, meaning that the pancreas is not making insulin. So you're dependent on exogenous insulin, or we call it juvenile, because it happens more at a young age. You have an absolute deficiency of insulin, an autoimmune process where we're attacking the islet cells of the pancreas, where the beta cells where they're made. So there's either a decreased number or decrease in the size. They're just not able to produce the insulin. And there's usually a long preclinical period with an abrupt onset of the manifestation, typically around puberty. So when you're real little, you can have manifestations of it, but a lot of times there's enough where it's okay until you go through the puberty change, and then it may manifest. Type 2 is really what we call the adult onset, right? This is you are not requiring insulin. You have insulin. The problem with it is it's not effective. You have a resistance to the insulin. And so it's an insulin resistance condition. It's there, it's just not able to sufficiently get your blood sugars from point A to point B. The way I sort of describe this is like, when you're trying to go from point A to point B, there's like a wall that's being built up. Now, depending on how high that wall is, it will depend on how it's manifesting in the body. So if, you put a wall of a couple layers of bricks, if you do the right thing, you can step over the bricks and still get the sugars from the blood vessel out to the tissues. There are things that we do to influence it. We basically can exercise, which is like pushing on the gas pedal. We push the gas out of the tank into the engine. We can eat better. We can not fill the tank up with so much gas in the first place. Don't put so much food and sugar in there. And then weight acts as a deterrent in the sense that it acts as a resistance between the blood vessel and the rest of the tissues. So diet, exercise, weight control, all things that influence sugars for better or worse. But we don't give ourselves diabetes. People often think this. They think, well, I did bad things. I got fat. I ate terrible, and I gave myself diabetes. We control the dimmer switch. We can make it better or worse, but we don't control the on-off switch. We actually don't know what causes that resistance in the first place, what causes that level of bricks to start popping up. And you can start doing all the right things. You can exercise. I got guys that are running marathons and eat fantastic diets and control their weight beautifully, but they still got that resistance. Their wall got built up, and we don't know why it is. We know it's there, but not the why. I actually have patients that are 400 or 500 pounds, and exercise to them literally is getting to the toilet or going to the fridge, and they eat terrible, and their sugars go from point A to point B. It's just the sugars, instead of being utilized as fuel source, they get stored as fat. And so they have more adipose tissue. There is a condition called type 1.5. It's kind of what we call the mature onset diabetes of the young, or MODY. It's really more like a type 1. It looks like it manifests like a type 2 diabetes, but it really is more insulin dependent. So it's kind of like a type 1 that manifests later in life. So type 2 diabetes, just you can't utilize the insulin to get you from point A to point B. And then, insulin or other medications, I think of as like a ladder that just you put up against the wall that's being built up to help you get over the wall. But when that happens, there's a progressive dysfunction of the beta cells. So your beta cells that are producing the insulin in the pancreas, they're trying to work harder to push the sugars out of the blood system. Well, they can kind of burn out. So you can lead to a condition where you aren't dependent on insulin, but you may require some exogenous insulin. So just because somebody's on insulin doesn't mean they're type 1 diabetic. And this process of type 2 diabetes is most of the diabetics we're going to see, up to about 95% of the cases. It's a slow onset, happens over time, happens, as people age. I've had diagnosis of type 2 diabetes early 20s. I've had diabetes diagnosed at 90. So it's something you have to keep an eye on, lifetime. Again, not insulin dependent, but maybe insulin requiring. It's that progressive disease by a whole bunch of different factors. And we know it's there. We don't understand all of the why, but what we can do to make it better or worse. There is an insulin resistance in the muscles and the adipose tissue. That's the main thing that's happening with type 2 diabetes. There's a ongoing progressive decline, a burnout, so to speak, of the pancreatic function. And then there's the inappropriate glucagon. Glucagon is basically a form of sugar storage, like in fats. It's just not a very productive use of sugars. And so there's an imbalance in the glucagon production. Again, model representing the homeostasis that we're trying to get. So let me get back out of here so I can use the cursor. So basically, if you get an imbalancing, let's say you have a very low blood sugar. Low blood sugar can kill you. I always tell people high blood sugars are bad over time. So if a high blood sugar over the course of years, bad things can happen. But a low blood sugar can kill you today. So if I have to risk it, I will let people be a little bit higher than lower, especially older patients. It's more dangerous to have them have low sugars. Each episode of a low sugar is a significant risk for their overall health, even their memory. They're more inclined to have significant memory impact or brain impact from each episode of a low sugar versus having high sugars over time. So we will let people have a little bit higher sugars if we're concerned about them dropping too low. But if you have a low sugar, your body says that's no good. You get this response where glucagon is going to be released, and your pancreas is going to try to both inject more not more insulin, but get more of this glucagon. It's going to go to the liver and to the fatty stores and try to break it down. It's a very inefficient process. It's very expensive from an ATP standpoint to do this. But they'll break it down, try to bring that back up, get you back up to balance. Versus if you have too much sugar, then the pancreas sees there's too much there, senses that, and it tries to produce more insulin so that the insulin will push that sugar out into the cells and will try to take whatever excess insulin's in the bloodstream and try to put it into the liver to try to store it, try to bring it back into balance. Diabetic symptoms, things that you want to know when you're just looking for diabetes. You can diagnose diabetes by doing blood tests, which is how we usually find it, but there are symptoms and clues that would tune you in to say there may be a problem. So when you have too much blood sugar in the system, you'll end up getting some of that sugar is going to spill out through the kidneys. It will be excess and will be absorbed, and so it'll push through the kidneys, and you'll see glucosuria or high sugar in the urine. Now, you're not really going to get symptoms of that, but people are going to come in and say, I got too much sugar in my urine. I'd be afraid to ask how they knew they had too much sugar in their urine. I'm not sure what they'd be doing to know that. I wouldn't want to know. But you will get symptoms. You get polyuria, polydipsia, and polyphagia. Now, polyuria is when you're peeing too much. So just like water follows salt, water follows sugar. So if you have too much too much sugar that goes into the urine, into the kidney, it's going to pull fluid with it. It's going to make you pee more. So if people are peeing a lot because they have high sugars, why don't they complain about it? Well, they don't think about it because when they pee a lot, it makes them very, very thirsty. So that's what the polydipsia is. They have excess thirst. But in their brain, we have this way of rationalizing things. So they're like, well, of course I pee a lot because I drink all this water. What they don't put together is that they pee first and then they drink water. It's not they're peeing because they're drinking because they're peeing. And then it can have polyphagia. They can have increased hunger, and you can have an excess of hunger and still have an unexplained weight loss. This is true, especially in type 1. So it reminds me of a patient that I had um, probably 20 years ago. And I had been on a medical mission down to Peru, which was a great experience. It was exhausting work, but it was completely rewarding to go down there. And this patient of mine had been down there with her boyfriend, and she had taken this month-long trek, hiking the Inca Trail. And she came back and she was severely underweight. And of course, I get all excited. And, you really never want your doctor to get too excited, right? If you say, oh, that's interesting, you really don't want that to be you, right? You want to be a very boring patient. You can be interesting as a person, but just be boring as a patient. So I'm all excited. I'm thinking, I'm going to have to get my tropical books out. Look at this tropical medicine, all these, exotic type of diseases, from this travel. Who knows what kind of parasites she may have. So I see her for this, and my brain's going in all these different directions. But I'm like, okay, well, let's get some basic labs on you. She just had diabetes, and so she had this process where she was losing all this weight because her sugars were actually running too high, and she just wasn't aware of it. But she developed it while she was down there. That being said, know about the uncommon things, but there's a saying in medicine that says when you hear hoofbeats, think of horses and not zebras, right? So common things happen commonly. So although I got all excited about it, it was diabetes, and we were able to control that, which is actually probably better for her versus some exotic, crazy type of illness. Diabetic complications. These are the things we're trying to avoid. And I always tell people who have diabetes, people don't get in trouble or have complications because of diabetes. They get in trouble because they don't know they have diabetes because they're not going to the doctor, they're not being seen, or nobody's checking for it. So they either get in trouble because they don't know they have it, or they decide they don't want to take care of it. They decide that they're not going to do anything to take care of it. But people who have diabetes can be controlled and the risk can be modified. But things we worry about is macrovascular disease. So, the retina being affected, the kidneys being affected, the nerves being affected. So retinopathy nephropathy and polyneuropathy are concerns that we see very frequently. That's why we always have diabetics have an annual eye exam. It's the only place that you can actually see the blood vessel in the body. So if you see blood vessels being affected, you know the brain and the heart and all the other organs are actually being affected as well. So eye exam every year for a diabetic is important. It's not about their glasses, it's a medical evaluation. Kidney disease, same thing. We are checking for their proteins. We're looking at their kidney function. And then we're testing their nerves with a little thing called a monofilament, where we're checking the sensation of their nervous system, especially in their feet. What you don't want to see is the late manifestations or maculovascular disease, where you're going to have the bigger problems like stroke, heart attack, myocardial infarction, peripheral artery disease, bad circulation. They get pain when they walk because they can't perfuse their tissues because there's too much of a blockage and oxygen can't get to the tissues when they need it. You also get a lot of tissue impairment with diabetes. So a lot of integumentary impairments, degenerative tissue changes, increased risk for ulcers and infections. Um, um, so you have diabetic polyneuropathy. So this is probably one of the biggest reasons why people end up losing their extremity, especially their feet. It's because they get a nerve damage down on their feet, and they just don't have awareness or sensation of this. And it is surprising to me how many people I have actually seen who come in with big holes in their feet because there's a neuropathy and they don't have any pain related to that. I had one guy who was literally probably 600 pounds, and he had a massive hole that was deep and wide. It was like, how he didn't never know his blood on his socks. I'm still dumbfounded by this, but he just couldn't see the bottom of his feet. So I tell people who are in that situation, you got to look at your feet in a mirror every day. But neuropathy in diabetics usually is symmetrical. It's usually going to be in both extremities. It happens in a stocking and glove distribution. So it's kind of like how you would put your socks on, how you put your gloves on. That's how you feel it from the end going up. It usually progresses moving proximally. So you may start with the toes and the feet and may move up into your legs later, or in your fingers and move up into your hands, although lower extremities are more common. But neuropathy is just an alteration in the sensation. So it could be just a numbness, but it could also be pain. So it could be a painful numbness, or it could just be a lack of sensation. But anytime you have that lack of sensation, you have a lack of a protective mechanism. This is like with having leprosy. People with leprosy have significant deformities because they have no nerve protection. So they have a lot of injury. They may put their hand over a stove or on a fire and it starts to burn, and they have no idea that it's burning because they have no sensation. So same thing with this. Diabetics, they have a lot of tissue damage because they don't have that protective mechanism. Pain is designed to be protective. Pain is not necessarily bad. I mean, we don't like to have pain, but pain is designed to tell us there's a problem, pay attention. You can have motor dysfunction and weakness. So we'll see this with diabetics where they have a lot of foot and ankle weakness. There's a lot of balance issues because remember, balance as a whole, I sort of think of as a three-legged stool. We rely on our vision, we rely on our inner ears, and we rely on something called proprioception, or the sensation of pressure changes within the feet. And if you knock one of those out, your risk for falls and gait impairment are going to go up significantly. Now, there are some things in the brain, the cerebellum, that'll affect that as well. But those are the common things that we use for balance. So I think that's an example of where we could be using our DPT colleagues better early on. Like when's the last time you guys have heard somebody getting referral for physical therapy because of diabetes? We need to really expand your guys' profession because you're going to have such a wide distribution of skill sets that are not going to be utilized. And that's why I think we need to get you guys into primary care much more frequently. We need to have hands-on on multiple medical conditions that you guys can have a significant impact on. So these are some things we'll see. So you can see on the right here, obviously the foot jumps out, right? You got a couple of different holes in the foot. And this is probably not painful. In fact, that lower ulcer on the ball of the foot probably was an ulcer that was forming underneath the callus. And so you cut the callus away, then you'll see there's this deep ulcer there. Well, obviously, if you get infection down into that ulcer and you can't get it cleaned up, because with diabetes, you can't get the blood cells to pass efficiently out of the blood vessels into the soft tissues to fight the infection. So the infection lingers and it's hard to treat, it's hard to get better. And that infection gets down into the bone, it's extremely difficult to get out. And sometimes the only way to get it out of there is to cut that portion off. So that leads to a lot of amputations for patients. The kidney we'll take a look at. You'll see the kidney function. You'll see diabetes will affect the kidney, it'll affect the glomeruli. So if you look at each functional unit of the kidney, so here's a healthy normal glomeruli. You got, say, blood flow that comes in, that's the afferent arterial. It filters through the glomerulus, through the Bowman's capsule, and then it comes out through the efferent, or the exiting blood flow. But this is basically like a coffee pot, right? This is a coffee filter. This is your coffee pot with your plastic filter. This is your coffee filter itself. Inside here, all the blood and proteins is like the coffee grounds. And you should keep all the coffee grounds and stuff here. It should come back out and float out. But if you have diabetes, you're more likely to start popping little holes in your filter, and little microproteins called microalbumin may start to spill out. Now, you can have big protein, that means it's just bigger holes. And we'll use medications like ACE inhibitors and angiotensin receptor blockers, which actually what they do is they dilate the flow out of the kidney, takes the pressure off of this. Now, something to be aware of, if you've got somebody on a blood pressure medicine like an ACE inhibitor or an angiotensin receptor blocker, ACE inhibitors always end in pril, lisinopril, captopril, benazepril, or an angiotensin receptor blocker, which are what we call ARBs. They usually are, telmisartan. They end in a sartan, telmisartan, olmesartan, losartan. Those medicines will dilate this, which is great for the kidney. But lots of people will be on those medicines, and then they will take anti-inflammatories for pain. Anti-inflammatories affect prostaglandins. Prostaglandins coat the stomach, which is why when you take it, it may upset the stomach. They actually decrease the inflammatory markers, which cause pain. That's why they feel better, because they're treating what's causing pain. But prostaglandins also keep the flow of the kidney open. So if you use a prostaglandin inhibitor like a ibuprofen or a Aleve medicine, then the flow going into the kidney gets shrunk down. And so you would decrease the amount of flow that is coming into the kidney. And then if you have a little flow coming to the kidney, and then you put them on an ACE inhibitor or an angiotensin receptor blocker, and then you push all that blood out, now the filter is not getting enough blood, and actually you can have renal dysfunction. This would happen when I was a medical student. I was doing my nephrology rotation in Rhode Island, at Rhode Island Hospital, and the surgical team would call us all the time. It's like, hey, we did surgery on this person, and now their kidneys are shutting down. Well, we would go see the patient, and they would have high blood pressure medicine, and then the surgeons didn't want to use narcotics. They put them on anti-inflammatory medicine. It's like, well, you're the one doing it. Stop the anti-inflammatory medicine, and the kidney should recover. So just something to kind of put in the back of your mind if you're seeing somebody with kidney disease or on one of those medicines, and they're seeing you and they're having pain issues, may just need to be aware of what's going on with the renal function if they're on anti-inflammatories. You can see here a healthy normal retina. You can see the blood vessels are nice and sharp. The tissues look very nice and healthy. You've got a healthy fundus. And then diabetic retinopathy, you can see, is like you're shooting holes. It's just like you're popping holes all over. You get little hemorrhages. Your blood vessels are blowing out. You can get what we call carpal wiring. The blood vessels start to change. So this is a very unhealthy eye. If it's happening here, it's happening in the brain, it's happening in the body, it's happening in the kidneys. So got to watch for those diabetic complications. Necrobiasis lipoitica diabeticorum. It's a condition basically where the sugars are there's a destructive process in the collagen and the fat tissues It's a degenerative process, which basically will break down the underlying skin, give you this dermatitis, but it thins the skin, so you're much more prone to infection. So it's a condition that you'll see in diabetics. Typically, it happens on the lower extremity on the anterior um, uh, uh, lower extremity on the shin. So just a condition to keep an eye on, very friable tissue. So musculoskeletal complications, you see this in the hands, shoulders, feet, spine. Carpal tunnel is much more common. Trigger finger is more common. An adhesive capsulitis or a frozen shoulder. Dish, we'll see in the spine. Diffuse idiopathic skeletal hyperostosis. I'll show you a picture of that. Is much more common than these musculoskeletal conditions that happen with people with diabetes. They're much more prone. They're more prone to get osteoporosis. We don't really know with type 1 why that's happening. Type 2, we see an imbalance between osteoclasts versus osteoblasts. So we're breaking the bone down more with the osteoclast cells. So fracture risk goes up. And then you get a person who is more obese, which is more common with diabetes. You get neuropathy, you get weak bones, their fall risk is high. This is a major, major risk, breaking a hip. Life expectancy mortality is significantly impacted in the first year after a hip fracture. So getting you guys involved with these guys early would be important. So this picture here on the left, you see this is hyperostosis. You get dish. You can see it's almost like this little excess of bone tissue that's going to form. It almost bridges the gap, almost like a fusion of the bone. But it actually, you can see where it can actually begin impairing the flexibility of the neck. You can see back here, here's your vertebral bodies, here's your disc, here's your foraminal openings. This is a condition called Dupuytren's contracture. Basically, it's a palmar fascia thickening. It actually can get to the point where it can contract the hand down so much where you can't even open the hand, and can lead to impairment. Now, just because you have the contracture, if you're functioning well, we usually won't do much with it. It's very hard to treat. You have to see a hand surgeon essentially. Potentially injections may help, but usually it's going to be surgery. But surgery is not going to restore you to a normal hand. Trigger finger, very, very common. You get one finger will go down and it locks and basically get a nodule on your tendon and sits inside of a tendon sheath, and you can pull it down. You pull that knot right down into the tendon sheath and the finger gets stuck. So it's like trying to open it, trying to open it, try to open it, try to open it, try it, and then it'll pop. So the idea of it like a trigger on a gun is going to pull, 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 and then release. Can be very painful. Will respond to steroid injection. If it's really bad, it can be opened up surgically. I don't see diabetic cardiomyopathy very often. It's not something that you'll see, but it's basically what we call the prayer sign, where you can't put the hands nice and flat. You get like this little opening. A lot of times it's a sign that there's a cervical spine immobility as well. So if you're an anesthesiologist, if you're diabetic, you may say, hey, can you do that? Because that may be a sign that it may be difficult putting an endotracheal tube in them. You can see it's either type 1 or type 2 diabetics. So how do you diagnose diabetes? This is something that really I think you guys should just be aware of. You're not going to make the diagnosis, but you actually should get in the habit, I think, of looking at charts. Who is the patient you're looking after? Well, you're not just there to rehab, you're trying to take care of this whole person. Who is this person? What are they dealing with? So there's several ways to sort of make this diagnosis. So the main way is a person has diabetes if his or her blood sugar, fasting blood sugar, which basically means like a minimum of 8, but up to 12-hour fast. Fasting does not include water. You can drink all the water you want. You can have black coffee, just no sugar or cream. But a fasting sugar of 126 on more than one occasion, that's consistent with diabetes. You can also diagnose this with what we call a glucose tolerance test, where we pump you full of sugar and then we monitor your response to that. Now, we hardly ever do that anymore, except for pregnant women. We do that for pregnant women looking for gestational diabetes. So we just torture the pregnant women. We don't torture the rest of the population. But if you have a response where the sugar shoot up after 2 hours, more than 200, that's consistent with diabetes. Important to know about during pregnancy because it can affect the maternal health as well as the fetus's health. If you have a random sugar over 200 with signs and symptoms of diabetes, in other words, they have blurred vision and they've got polyuria, polydipsia, polyphagia, poor skin healing, those type of things, then that's also a way to make diagnosis. The way we probably make it more commonly than anything else is with this test called the hemoglobin A1C, where basically sugars get stuck on the outside of a red blood cell. And once they stick, they stick. They stay there for the lifetime of that blood cell. And red blood cells typically last in circulation for about 120 days. In that time period, the higher the sugar in the blood, the more of a percentage is going to be stuck on the outside of that cell. So excess of sugars in the bloodstream, you'll have a higher percentage on the A1C. Now, normal sugar average depends on the lab, but typically it should be 5.7 or less. If it's above 5.7 but less than 6.5, that's what we call impaired fasting glucose. A lot of doctors like to call this pre-diabetes. It may be pre-diabetes, it may not be, but that's kind of that in-between stage. But if it's over 6.5%, that's consistent with diabetes. I like the A1C because for me, it's like looking at the big picture. If I check a blood sugar at that moment, it's like looking at one tree in the forest. If I look at the A1C, I get a step back and I get to see the entire forest and see the big picture of the sugars. Diabetes management, the main thing is to control the sugar level and the insulin production is needed to meet that homeostatic balance. Always start with dietary controls. Even if you're on medicine, you still want to have the the dietary controls. It's very common people will get on insulin and they'll say, oh, my sugars are worse with the insulin. It's making it worse. No, really what's happening is they have insulin, so they think they can do bad things. They eat worse. And that actually just is the problem, is they're overcoming the effect of the medicine. But weight control, weight reduction, control of what you're putting in your system, reducing the carbohydrates, watching your portions for the most part, is big factors, and exercise, because it helps drive the sugars out. So weight control, exercise, diet control, are big factors of controlling sugars. When that's not enough, that's when we get the ladder out. That's when we get the medicines out to help you get over that wall. That's when we'll use oral hypoglycemics. That's really something we'll use in the oral medicines with type 2 diabetics, not type 1, because remember, type 1, insulin dependent. They need insulin. Type 2, they need something to help them get over the wall, whatever that may be, because type 1, it's not that there's a big wall, it's that you just don't make any insulin to help the sugars go from the blood vessel to the rest of the tissues. You want to maintain normal cholesterol levels. Statins become very, very important with diabetics. It helps maintain plaque stability, decreases plaque rupture, and controlling blood pressure is significantly important in this as well. Um, I'm going to just kind of give you a couple highlights on the exercise because I have to admit I have no idea how long I've been talking for, and I apologize if it's actually more than the hour and a half. So I'm just going to, you guys can read through this, but a couple big things with sugars and exercise. You want people to exercise with diabetes. So if your sugars are 100, 250, you're in a pretty safe zone because when you exercise, you're going to drop your sugars, or at least you should. If your sugars are very low, you may think about trying to do something before you go out and exercise to avoid dropping it low. I had a patient, he was an older guy, he's in his 80s, and he would go to the gym every day. And he kept having these low episodes of sugar. And I figured out, I was like, well, what are you doing? He'd get up in the morning, he'd take his insulin, he wouldn't eat, and he'd go to the gym and he'd bottom out. So I'm like, oh, it's like, don't take your insulin before you go, or take a snack or something so you're not just driving sugars down without them being up a little bit. But it's symptom dependent. If you have normal sugar, no symptoms, you can proceed cautiously and move forward. Now, the more you're in routine, the more how you know your body's going to respond, the safer that's going to be. But always be looking for what your sugars are, how they respond to exercise. Be careful of diabetic ketoacidosis. Basically, ketones, you can see those and you can smell them in the breath. It's kind of a fruity smell. It's basically trying to utilize fat as a fuel source and break that down. There are some symptoms of diabetic ketoacidosis, which is really life-threatening. So the fruity breath, the acetone breath, you get dehydrated. So dehydration, weak pulse, weak and rapid. Kushmal breathing, very deep labored hyperventilation respirations. Don't exercise. This is fix the ketosis before you do anything. Anyone who is low, you got to correct it. The best way to correct it really is to get something that can be absorbed very quickly. So we like juices the best, really, like orange juice, because it absorbs very, very quickly, get in your system. There are lots of other things you can do to bring the sugars up, but the faster you bring them up, the better. Um, some things you can look at before exercise, during exercise, regular exercise, and what your body's going to do is really the key. Make sure you hydrate and monitor the sugar. And if you're a diabetic and you're not sure what your sugar is going to do, don't exercise alone. Have a wingman. Make sure somebody's watching out for you. And after exercise, make sure you are kind of watching the sugar levels. Make sure you're monitoring those, especially if your exercise is not consistent. You know, right after New Year's, everybody wants to get out and hit the gym, and don't really know what your body's going to be doing. You want to increase your calories after you exercise, especially in the first 12 to 24 hours. What you don't want to do is like, exercise late at night, have some insulin, not know what your sugars are doing, and the night goes on, you bottom out throughout the bottom of the end of the night, and then have a hypoglycemic episode during the night. Guys, I hope you have a great week. I hope this was helpful. I'll be around next week if you got any questions to go over. But have a great week and be a good wingman. I'll see you next week.